So today we have the pleasure of Dr. Sylvie Lambert, who will be presenting to us. You need something like this to give you guidelines on what to do, development and initial evaluation of a self-directed coping skills training resource for patients with cancer and their partners. So Sylvie, I'll turn it over to you. You give a presentation and then we'll leave time for questions of all the participants today afterwards.
Great. Well, thank you, Catherine. Well, good afternoon, everybody. I'm really happy to be here today and have the opportunity to present on the development and initial evaluation of a self-directed coping skills training resource for patients with cancer and their partner that we called Coping Together. I'm originally from Montreal, from McGill University. I graduated from the PhD program, the School of Nursing's PhD program in 2008. Shortly thereafter, I was very lucky in getting a 2-year postdoc position with the University of Newcastle in Australia. Then I joined the University of New South Wales as a National Health and Medical Research Council Fellow, and that was for an additional 2.5 years. So I lived in Australia for almost 5 years, and most of the work that I'll be presenting, well, all of the work that I'll be presenting today was conducted during that time. I moved back to Canada. I am back in Montreal, actually back at McGill. I joined the School of Nursing faculty a 1.5 years ago. The projects that are part of my psychosocial oncology program of work mainly focus on better understanding the substantial impact of cancer on patients and their caregivers, and I'm particularly interested in the interdependencies among patients and caregiver outcomes. A few of my projects also focus on developing and evaluating self-care and illness self-management interventions for patients and their caregivers, including evaluating different health service delivery models that have more potential to be translated in clinical practice, and also evaluating the methods that we use in psychosocial research, particularly using item response theory to evaluate the measures that we commonly use. So for the next 35 minutes, I'll be presenting some of the key findings from Australia's first longitudinal Partners and Caregivers Wellbeing Study that was conducted mainly in the first few years that I was there as part of my postdoc. And the findings from this study, particularly in terms of anxiety and depression, really informed or really guided us in developing our Coping Together intervention. So then I'll focus on how we went about developing and some initial evaluation. This program of work, the Coping Together program of work, is still ongoing in Australia. So my program of work and most of the projects that I conduct are focused very much on the partners and caregivers or have a dyadic focus. And although research has traditionally focused on the negative impact of cancer on patients, really the past decade has seen a marked increase in the attention given to the ripple effects of the diagnosis and treatment on patients' primary support person, and that is their partners and family caregivers. Cancer is actually the second most common condition in Canada requiring help from family caregivers, and reliance on them is only expected to continue to grow, particularly as the course of cancer is changing from an acute to a chronic disease, and the setting for cancer care delivery is shifting from the hospital to the home. And although caregiver support reduces the demands on the healthcare system, that is well documented, and their support positively impacts on how well patients adjust to the illness, it does come at a particularly high cost to caregivers' own health and functioning. A number of studies have shown that partners and caregivers experience many health problems as a consequence of their roles. Most prevalent ones include fatigue, pain, and loss of physical strength. As partners and caregivers experience change in expectations and family responsibilities, they often feel stretched in many directions and struggle to remain afloat with their own life priorities. It is not uncommon that partners and caregivers need to reduce the number of hours that they work, with impact then on their financial status. And depending on patients' diagnosis, partners and caregivers also face a number of complex illness management tasks, and the point here is that they typically face these with little to no formal training. A number of studies have also found that partners and caregivers experience many emotional challenges that are analogous to those reported by patients, including shock, anxiety, and depression, but that these are actually experienced more intensely in partners and caregivers. The responsibilities that cancer caregivers take on has in turn prompted much interest into the kind of support that they need. This is often referred to as supportive care needs, and our team has just recently completed a systematic review examining their unmet supportive care needs. So where do partners and caregivers need more support? This review found that actually up to 68% of caregivers report needing more support, and of note, these rates actually exceed those reported by other systematic review examining unmet supportive care needs among patients. Our review actually identified 6 domains of unmet needs. The first one, comprehensive cancer care, where prominent needs within this domain included awareness of available resources and having a sympathetic relationship with healthcare professionals. The second domain, emotional and psychological, prominent unmet needs there were needing emotional support and guidance on dealing with not only one's own emotional distress, but also patients' emotional distress. Financial support and knowing how to maintain a sense of control over the situation were 2 prominent needs within the third domain of partner or caregiver impact on daily activities. And most prominent unmet needs were within these 3 domains, but we also identified important unmet needs within the relationship domain, information, and spirituality. And the most prevalent ones were help communicating with patients about illness, information about what to expect, and feeling that there is some hope for the future. So although we know quite a bit about what are some of the challenges that partners and caregivers face, and how they adjust to the cancer diagnosis and their roles and responsibilities, there are a number of gaps in the literature that remain and warrant additional studies, particularly that most studies are cross-sectional, have a small sample, so we're talking about less than 150 often, and focus on particular subgroups of partners and caregivers, particularly those of women with breast cancer or men with prostate cancer. And it is because of these limitations that our group embarked upon Australia's first longitudinal study of partners and caregivers of patients diagnosed with one of the 8 most common cancers in Australia. And the main aim of this study was to describe changes in anxiety, depression, quality of life, and unmet needs, and identify variables associated with these outcomes. Our participants were given a survey at 6 months, 1 year, 2 years, 3.5 years, and 5 years. This survey was quite comprehensive and included a number of well-known surveys to measure the variables of interest. For today's presentation, and moving into the presenting the intervention, I'll focus on the anxiety and depression data, because it's very much that those variables that then informed the focus of our Coping Together intervention. And I'll focus on the first 3 data collection time points. The demographics of our participants in this study were comparable to those reported in other studies. At baseline, more than 2/3 of participants were female. The mean age was 60.5, and most participants were actually the partner of the patient and living with the patient. The 3 most common cancer diagnoses of the patients were prostate, melanoma, or breast cancer. So in terms of findings, what did we learn for anxiety? Well, we learned that at baseline, the prevalence of anxiety, so the blue bar, and this is defined as a score of 8 or more on the hospital anxiety and depression scale. That was the scale that we used. The prevalence of anxiety among partners and caregivers significantly exceeded population norms as measured by the HAS. Although there was a significant decrease in anxiety over time, at each time point, the prevalence of depression, the prevalence of anxiety reported by partners and caregivers significantly exceeded the rates reported by the patients themselves. So although we expected that with time we probably would see a decrease in anxiety, we definitely did not expect that at each of those time points there would be the anxiety among partners and caregivers would significantly exceed what was reported by the patients. For depression, both at 6 and 12 months, the prevalence of depression among partners and caregivers also exceeded population norms. And similarly, there was a significant decrease in depression over time, but only at 12 months did the prevalence of depression reported by our partners and caregivers significantly exceeded the rates reported by the patients. So although the data that I presented on the previous 2 slides indicate that as a group, partners and caregivers' anxiety and depression decrease. However, we can hypothesize that for some subgroups, it's possible that their anxiety or depression does not get resolved, or others might experience an increase in anxiety over time. We don't get that from a lot of the summary data that are presented in longitudinal study, and definitely in what I presented in the past 2 slides. And what we wanted to do is definitely be able to tease out these different subgroups, because these are probably some of the subgroups that we're most concerned about. And to be able to do this, we conducted what's called a trajectory analysis. And I'll be presenting the results of this trajectory analysis now. So these are our findings for anxiety. So just as a reminder, we use the hospital anxiety and depression scale, where scores of 8 to 10 are categorized as borderline anxiety, and scores of 11 or more are categorized as clinical anxiety. So what we found, again, looking at the first 3 data collection time points, is that 2 groups of partners and caregivers did not experience anxiety at a level that was of concern. So where you see the group 1 and the group 2. So that does represent almost 50% of the sample. But where we're concerned is that we do have a group, and this still represents 1/3 of the sample, and they experience what we labeled as chronic levels of borderline anxiety. And even more concerning, we have 14% of caregivers experiencing chronic levels of clinical anxiety. And it's chronic because, as you'll see for the 3rd trajectory and the 4th trajectory, these are almost flat lines. Although for the 4th trajectory, there is a steady decline, and it'll be interesting as we further analyze the data to see whether that decline becomes more pronounced with time. But despite that decline, they still remain above the cutoff point for clinical anxiety. And I do want to emphasize that this is at the end of 2 years. For depression, similarly, we have 2 groups reporting levels of depression below the borderline cutoff score, but they represent a much larger proportion of the sample. We do have about 1/4 of the sample that reported close to the borderline cutoff point scores across time, and 4% of participants, recognizing it is a smaller subgroup, reported chronic clinical depression. So these analyses led us to conclude that distressed partners and caregivers do not recover easily. Our next set of analyses focused on identifying what are those risk factors of being in the top trajectories, and being in those trajectories of chronic levels of clinical anxiety or depression. We looked at a number of demographic variables. We also looked at psychosocial variables. None of the demographic variables predicted membership to chronic levels of anxiety or depression using logistic regressions. But however, in terms of psychosocial variables, we noted that high avoidant coping, low social support, high caregiver burden, and high unmet supportive care needs predicted membership to chronic anxiety and or depression. And so with those early analyses of our longitudinal partners and caregiver study, we were slowly thinking about what are some of the potential interventions that we should be putting in place. And given some of our analyses, we definitely knew that we wanted to implement an intervention early on to really try to help with partners and caregivers recovery in terms of anxiety. So as much as possible within the first 6 months post-diagnosis, but an intervention that could be sustained over time. We knew the risk factors that we would want to target, recognizing that these are risk factors that have also been identified to impact on patients' adjustments and outcomes. And also at that point in time, so we're talking about 2009, there was some literature emerging documenting that patients and partners react to the cancer diagnosis as an interdependent emotional system where their anxiety and depression are moderately positively correlated. So although when conducting our longitudinal study, the intent was to develop a caregiver intervention, we really then shifted our mindset to think about a dyadic coping skills training intervention. And that was then the focus of our intervention work. At that time, when we turned to the literature to see do we need to develop our own or do we need to think about adapting an intervention, we turned to the literature and found that there were about 12 studies that had been already published. These studies were very encouraging in terms of the impact of these dyadic interventions for both patients and their caregivers in terms of increasing quality of life and self-efficacy, increasing adaptive coping, relationship functioning, social adjustment, positive illness or caregiving appraisal, as well as decreasing physical and psychological distress. So that was encouraging, and we further pursued the idea of focusing on a dyadic coping skills intervention, but we also realized that these interventions had a number of limitations, with the ultimate goal of being highly translated into clinical practice. The fact that a lot of these interventions were delivered by highly trained health professionals really limited their long-term sustainability. All of the interventions that we reviewed, to our knowledge, had not been implemented in practice, mainly because of their high cost and limited availability of qualified health professionals. A review that we conducted also revealed that the uptake of couple-based interventions are actually often low by even the patients and their partners, given the current formats that are being used. And often it's because they're not necessarily willing to travel to for the intervention, or the intervention is offered at a time that caregivers are not available, particularly when this does require maybe taking time off. It's just not feasible for them to make it to the intervention. So then we thought, well, we really need to think about an intervention, a couple-based dyadic intervention that is cost-effective, sustainable, and efficacious. So we turned towards a number of alternate formats for our intervention. There was definitely some discussion about having a group-based intervention. However, a meta-analysis found among patients, not among caregivers, that individual treatment approaches had significantly larger effects than group approaches for distress. So we were wondering whether this was an efficacious format for our intervention. But more importantly, we felt that this did not necessarily resolve some of the caregiver barriers previously identified in terms of accessing our intervention. Telephone-based intervention was also something that was proposed, and whether we should go that way. It's a format that is extremely popular in Australia, given that a lot of the population are in rural and remote areas. So people are used to that intervention format, but still mixed efficacy studies, mixed evidence in terms of their efficacy really put into question this format. And also we weren't convinced that some of the barriers that I mentioned previously in terms of still having to be on the phone at a specific time would really resolve some of the accessibility barriers. We then got very interested in a self-directed or self-administered format, particularly with some of the work of Paul Jacobson in the U.S. among patients, and we found that this was an acceptable format to patients. It increased accessibility and sustainability as well. There were no self-directed couple-based intervention at that point in time, but we felt that what caregivers were indicating in the literature in terms of access barriers, we felt that this was probably the most promising delivery format for our intervention. So therefore, we developed self-directed coping skills training interventions for patients with cancer and their partners. The core component of Coping Together is a series of 6 booklets which translates the most up-to-date evidence on adaptive coping strategies and present these to couples as suggestions to address specific challenges across 6 topics. The topics are getting on top of symptoms, dealing with stress and worry, supporting each other, getting what you need from your healthcare team, making your treatment decisions, and getting the support you need. Now, at this point in time, you might be wondering, did we really need another series of booklets? Was this necessary? We definitely, at that point in time in Australia, most of the resources that were available very much address what is cancer and what is treatment, as do a lot of the resources here in Canada. There is definitely a lack in terms of really presenting to the couples some of the strategies that were evidence-based that we knew could make a difference in their daily lives. So the focus was really on translating that evidence base to make it easily accessible to patients and partners. So the booklets, every booklet starts with a flowchart, as you see on this slide, on the slide that's up right now. And this one is from Getting What You Need from Your Healthcare Team booklet. And on the left-hand side, you see that within this booklet, we address 6 specific challenges related to this topic. And the second column right away on the right-hand side, the matching strategy. And every booklet starts the same way, where the challenges are quickly identified, as well as our suggestion of how to address these challenges. In addition to the booklets, the Coping Together intervention includes a DVD, which features clinicians who explain key aspects of the booklet. It also includes role plays with couples, not giving a testimonial, but really demonstrating specific coping skills. And often we give a scenario of how, using that coping skill went well or didn't go well, and what are some strategies to overcome barriers to implementing some of these coping skills. There's also a Learning to Relax CD, and this was made available through the Cancer Council in New South Wales, which is equivalent to our Canadian Cancer Society. There's a very good booklet, very good CD, which provided a step-by-step guide for key relaxation strategies described in our Dealing with Stress and Worry booklet. We also have a website that really acts more as a repository for the booklets, the PDFs of the booklets, and the videos for the DVD. It does not take advantage as much as it could of the online platform, and that's because in our feasibility testing, participants told us that they did not want a web-based intervention. So the website is there and will be further developed as we move along in terms of testing whether an online platform now, it's 5 years later when we started developing this intervention. It was early 2009. So as we move forward, we are going to use it as our platform to further develop and take advantage of the online platform, but it's not there at this point. So what you saw on the previous slide is really the final version of Coping Together. It did not start out that way. Coping Together is a program of work that has 3 phases. We began the development in 2009. We then embarked upon a pilot study with men with prostate cancer and their wives. And recently we began the recruitment for a large randomized controlled trial. So for the purpose of today, for the second part of my presentation, I will be focusing on phases 1 and 2. I do hope that maybe within a year or so I can come back and present some of our data for the randomized control trial, but recruitment is very much ongoing for that phase. So in terms of phase 1, as soon as we began the development of the booklets, we presented these to couples to obtain their feedback on the appropriateness and to gain a sense of whether they were willing to use the booklets to learn about coping strategies and how does that work within a dyadic context. So this initial qualitative feasibility study included 27 patients and 12 of their partners. Across the patients and partners that we interviewed for this feasibility study, we did get quite a bit of variability in terms of time since diagnosis, really ranging from a few months, to well into long-term survivorship. Variability in terms of cancer type is also noteworthy to a certain extent. Our semi-structured interviews identified 3 strengths of our intervention design. The first strength was really that it was a self-directed format. That was clear not only for the partners, but also for the patients. And for both patients and partners, that was in preference to, for example, attending a support group. So we were quite encouraged that not only for our primary target population, which was the partner, we were reaching a subgroup that normally then would not have accessed additional service, but this was also true for the patients. The second strength of the booklet was that we were targeting both patients and partners. And for many of the partners, they had not received any other resources that was specifically meant for them. So they often read what was given to the patients, but partners and caregivers are often a secondary focus of many of these resources. And it was quite comforting for the patient to know that their partner now was receiving something that was meant for them. The third strength of our intervention, identified through this initial qualitative feasibility testing, was its focus on practical coping strategy. And we hypothesized that this was the feature that would set it apart from what was existing now, and patients and partners confirmed that for us. So they had received from the Cancer Council what is cancer and what is treatment, and healthcare professionals had given them the information, but also they were often told you need to relax and you need to communicate with your partner and you need to do this and you need to do that, but nobody was telling them how to do these activities or initiate these strategies. And that's where Coping Together picked up for many of the patients and the partners. The strategies that we proposed were felt to be plainly spelled out, they were doable, and that sufficient details had been provided to understand the strategies. And on this slide, I'm just giving you some examples in terms of some of the strategies that were popular among our patients and partners. So for those participants that were previously unaware of the strategies, definitely our intervention seemed to actually develop their repertoire of coping skills. Whereas for those already using the proposed strategies or those that had used them in another context, Coping Together really confirmed that they were on the right track, that these are strategies that even if they were used in other contexts can be used in the current context, in the current cancer context. So they had the skills, but many of the participants were actually not sure whether it also applied to this current context, to their current context. So the primary purpose of Coping Together, based on this initial qualitative study, seemed to be feasible. It seems to be feasible that we can expect couples to learn through our resource some of the coping skills that they need to address their challenges. So we were quite encouraged by this initial testing, but there were, through these interviews, there were also a number of secondary benefits that were identified by using this resource. This included having a sense of, the resource provided a sense of normalcy or hope that something can be done to pull through. So just knowing that someone else has been through the same situation or is going through the same situation, and recognizing that these issues, that's not you that are experiencing these issues, was comforting for many of our participants. And Coping Together also had the secondary benefits of connecting patients and partners to people and services. So we also always had a resource page, and it was interesting to find that patients and partners often did not know the roles of their different healthcare professionals or did not know some of the community resources that were available to them. But Coping Together really, really emphasized who they can go and talk about with these issues, and also what are some of the potential community resources they can call upon. And the last secondary benefit is that in many cases, the book was complemented the information participants had received from their health professionals, but it provided more details about how these coping strategies can be implemented. Often, healthcare professionals had mentioned these coping strategies, but very much in passing, and had not really provided the information that was needed to be able to implement these. So these findings are from really were encouraging for us in terms of some of the benefits, but I should note that this did come from about 50% of our sample. It should be noted that the other 50% of our sample did not really use the intervention at the time that we interviewed them. And so we actually spent a lot of time talking with them. What were some of the barriers to using this intervention? And I think that's one of the disadvantage of a self-directed format in terms of it does require a lot of motivation from the patients and the partners to open the envelope, read through the booklet, identify when they have a challenge that is relevant for the coping skills that we are trying to communicate, then learn the coping skill, implement the coping skill. So it's a lot of steps, and in some situations, the way we had tried to facilitate that process was not successful. And so a lot of barriers were identified during the interviews, but also a lot of strategies. And then we spent a lot of time then modifying our intervention, integrating the strategies that patients and partners had mentioned. And I just want to review a few of these with you, because they did seem to make a difference in the end. So although we were going with 100% self-directed format, our participants really felt that if they had been provided with an initial workshop or an orientation session, whether that was face-to-face or over the phone, that would have made a difference. People receive a lot of mail, a lot of packages. They were receiving packages from the Cancer Council at that point in time. Depending on their diagnosis, they might have been receiving some from the Australian Breast Cancer Foundation. And so they're receiving a lot of information. and the benefits of coping together were not obviously apparent just by the package. So receiving a phone call that would really emphasize those benefits would have maybe helped with use. A second strategy that was mentioned was to tailor the information to their characteristics. Now, this is challenging in a manual-based format. When this was raised with us, we did talk about whether an online format would be more relevant, but in our feasibility testing, it was almost 100% for patients and partners that an online format was not favored. And so having to tailor the information is challenging for a print-based resource. So what we did is that we actually developed those flowcharts. So the flowchart really came out of the feasibility testing so that we make it very easy for individuals to self-tailor. A third strategy was to present the information in a concise way, to be very, very point form. So initially, for each section of the booklet, we might have had 7 to 10 pages. We then called it down right away to 3 to 5 pages. And so as soon as partners and caregivers would go on the first page of a section, they would have access right away to the information that they need. They also suggested that we should have a DVD, which we did produce. As well as page turner, the booklets were felt to be too clinical, unattractive. People felt that they were in a therapy session reading the booklets, and so they really suggested that we have a page turner, which included for them, which meant for them having testimonials and cartoons with captions. And there's actually evidence that have shown that including cartoons with caption in print-based material actually enhances comprehension and retention. So we did exactly that, and our cartoons actually illustrate the coping skill that we're actually talking about in a given section. And so as we integrated all of those strategies, it did take quite a bit of time, especially to produce the DVD. And once we were ready, we finally embarked upon our pilot testing. Our pilot testing focused on examining the acceptability of the methods to evaluate coping together in a larger trial that we were aiming for, and collect preliminary efficacy and cost data. In this study, a convenient sample of 42 men diagnosed with early-stage prostate cancer and their partners were recruited across 6 sites in Australia and randomized to what we call the minimal ethical care condition, which is referred to as MEC, or to coping together. The patient inclusion criteria were diagnosed in the past 4 months, receiving or planning to receive treatment, and this included for our pilot active surveillance, having no previous cancer diagnosis, and having a partner willing to participate. For us, a partner was a spouse, boyfriend, girlfriend, or de facto. In addition, to be eligible for this study, the patient or the partner had to score 4 or more on the distress thermometer at the time of recruitment. All couples completed a baseline survey, and they were asked to complete a survey 2 months later. They were also asked to complete a cost diary and to participate in a series of phone interviews. So this is the flow chart just to illustrate the study methods. Coping together couples received the intervention material within 2 weeks of returning their baseline survey. And for our pilot, we had 4 of the 6 Coping Together booklets available. So it focused on getting on top of symptoms, getting what you need from your healthcare team, supporting each other, and dealing with stress and worry. Couples did receive the relaxation CD. That was the first time that they got the CD, and a DVD, which featured mainly one of the booklets, which was the Getting What You Need with Your Healthcare Team. So 1 to 2 weeks after receiving Coping Together, we did call them. We did institute the orientation phone call for this pilot, And then couples also received a follow-up phone call every 2 weeks to really monitor use. So we were very much focused on process evaluation as well in terms of knowing the extent to which couples were using the booklets, particularly given all the changes that we had made. Met couples, so our control group, they were mailed 2 booklets that were already available in the community through the Cancer Council, and this was Understanding Prostate Cancer and Caring for Someone with Cancer. They received the same number of phone calls, and they were all similar in intent and content. None of the phone calls had a therapeutic focus. They were conducted by a trained research assistant in terms of the interview guide, but this was not a research assistant that was trained in terms of any therapeutic, to institute any therapeutic interventions. So the close monitoring of couples' use of Coping Together, we found that in our pilot, and I'm still analyzing this data in terms of characterizing patterns of use and understanding that it is a different sample. But we are quite encouraged because 70% at this point in time of our couples actually use Coping Together in a way that, in the way that in which Coping Together was designed. So that is encouraging to us. Phase 2 was a pilot, so I can only present trends in efficacy. I do really want to emphasize that. But this table does show that for Coping Together partners, there are a number of potential benefits. Obviously, our larger trial will hopefully confirm some of these, but just in terms of sharing with you some of these potential benefits, these include increased relationship satisfaction and self-care initiatives and reduced caregiver burden and negative appraisal of caregiving. So to a certain extent, that is encouraging to our team. So phase 3, our large randomized control trial, is ongoing at this point in time, and I do hope that in the near future I'll have the opportunity to present these to you. So thank you very much.